Welcome back to Oncology for the Inquisitive Mind, featuring Michael and Josh. Just popped up that we needed more power, so I don't know what that means, but this week and for the next couple of weeks, we're doing our ASCO 2025 reunion tour. Something fantastic. We're going to have a host of great guests, both domestic and international, and we think you're going to love what we've done this year. We're going to talk about the pivotal trials, the up-and-coming trials, things that might change the way we look at trial design, all the things that you ask when you go to bed. What can we make better in the world of oncology? And I could not do this without my co-host, my squire, my knight in shining armor, Dr. Michael Fernando. Michael, so good to see you.
It's great to see you too, Josh, and very interesting that I'm both a squire and a knight in shining armor. Multi-talented am I. But yes, we are very excited to start on our ASCO 2025 journey. Josh said this take a couple of weeks. I personally think that we're going to be doing so many episodes, it'll be ESMO time by the time we're done. But other oncology education podcasts might string you on, dear listener, and leave the plenary sessions right to the end. We have been guilty of that, but Josh, I think you'll agree, we are not just any oncology education podcast. We are Oncology for the Inquisitive Mind, and we cut right to the heart of the issue.
That we do. That was very, very pro our podcast, Michael. So I am very, very pro this episode as of right now. And Michael, if you're ever in court, you can be your own lawyer as well. So a squire, a knight, and a lawyer, and I will be there to clap you along.
I am just hitting all the boxes today. But yes, it's I like that you semi-imply that you were anti this episode before I started talking just then.
Yeah, so Michael, we haven't figured out who's actually going to talk about the first trial, but I might give that one to you because
Sure.
you are, you're breaking atoms, you are the man of the hour. So why don't we talk about Atomic?
I am just like a massive mushroom. You can call me a fun guy. There we go.
Michael, that's just your hair today.
Oh, yeah, that's true. If you're on YouTube, you can attest to that and comment on the mushroom-like qualities of my hair and compare it to Josh's. But anyway.
And don't forget what sort of haircut Michael should get for the next episode.
Absolutely. If we get enough subscribers, I'll shave my head. I won't do that.
I'll shave his head. I'll shave your head, Michael, if we get enough subscribers.
Good. It got worse. Anyway, Atomic. So... of the plenary studies, Josh, I think that, it's like saying who's your favorite child. You really shouldn't say which one is your favorite, but I think we both have our favorites, and this is mine because it's a colorectal cancer study, but it is focusing on dMMR colorectal cancer in the early stage. Now, there's been a lot of study and a lot of interest in this particular niche, some might say, with the niche 2 study showing neoadjuvant dostarlimab having a overall response rate of 100%. And we will come back to niche 2 at the end. But Atomic is thinking or looking at the question from a different perspective, and it's looking at adding adjuvant immunotherapy to adjuvant chemotherapy, the immunotherapy agent in question being atezolizumab. Now, most of our listeners will probably know, but a quick refresher on MMR or mismatch repair in the colorectal cancer setting. MMR refers to a series of genes that are responsible for repairing errors in DNA matching, hence mismatch repair. They consist in general of 4 major genes. These are the assays or the genes that we look for on the standard assay. That is MLH1, MSH2, MSH6, and PMS2. Germline mutations in these genes tend to indicate Lynch syndrome, but sporadic mutations in MMR usually manifest as the loss of MLH1 by itself. Loss of any of these 4 constitutes a deficiency in MMR. Deficiency in MMR is present in approximately 10 to 15% of colorectal cancer, so it is a small but significant cohort. And it is associated with better prognosis in stage 2, although if you go really deep into the literature, as I've been doing with some research that I'm a part of, it's very, very murky about what prognostic benefit, if any, DMMR actually provides overall. But it may also confer resistance to single-agent fluorouracil-based therapies. So single-agent 5-FU is not recommended for patients with DMMR colorectal cancer. Of course, we have evidence in the metastatic space for efficacy of immunotherapy. There's Keynote 177 with single-agent pembrolizumab, and more recently Checkmate 8HW with ipilimumab and nivolumab, which have demonstrated the benefit of either single or doublet immunotherapy over chemotherapy. And the reason for this is thought to be due to the increased mutation burden. If you have lots of mismatches in DNA repair, you have increased mutations, and that's just a big red flag to the immune system, which can be stimulated and exacerbated by immunotherapy. So Atomic asked, can we take immunotherapy, atezolizumab, and add it to the standard of care chemotherapy, which has been the standard of care for stage 3 colorectal cancer, or colon cancer in this case, because rectal cancer is its own separate thing, for about 20 years, pretty much since Mosaic in the early 2000s. So basically, a very simple study design with a randomization 1-to-1 for patients to receive 6 months of FOLFOX plus atezolizumab, followed by 6 months of atezolizumab on its own, compared to 6 months of FOLFOX and then just finishing. The major eligibility criteria, you had to have confirmed R0 resected stage 3 colon adenocarcinoma, and that is a point that we'll come back to. It had to be confirmed DMMR by immunohistochemistry. This could be done either centrally or at the local site. And patients had to have no prior chemotherapy and radiation. So this is a first-line study. Patients were stratified. Yeah, sorry.
Can I ask you something? No. 2 questions. We were live in the early 2000s, but you didn't see my chat comments, so I'll say it out loud. Had to. But quick question.
I was alive in the early 2000s, yeah.
Good to know. The idea meta-analysis, and I know we've given ourselves time limitations. They've got 6 months of FOLFOX. Question, and you do far more colorectal than I do, but 3 months of FOLFOX in this cohort. Could you use that? Is this the optimal trial design?
Well, it's a very good question, and 3 months of CAPOX it would be.
Because
they found that 3 months of FOLFOX was actually inferior in the idea
That's
collaboration.
How good
But it is a very good question, because what that, and we won't go too much into detail, like you said, time restrictions, but basically there are a proportion of patients, and we'll come to that, the way they've classified high risk and low risk, but those low risk patients may get away with only 3 months of CAPOX. And so there are a proportion of patients in this study that, according to standard care, you are over-treating. I suspect it's sort of, there are 2 reasons for that. One is practicality. It's probably hard to do investigator choice, CAPOX and FOLFOX when you're adding something on top of that. Yeah. Number 2 is this study started recruiting roughly around the same time that IDEA came out. And so it took the 3 months versus 6 months probably hadn't quite filtered into standard practice and supplanted it as it has today.
Interesting. That is a great answer. Thank you for answering my question,
It's
Michael.
almost like we think about these ahead of time. So I will touch on that high risk versus low risk. So basically, the majority of patients in the study, 712 patients were recruited. Majority had T3 primary as an N1 nodal status. About a third of patients had either T4 or T2 nodal status, but you put them together. So T4 and N2 are the high-risk features, really. But then you put those 2 groups together, you mash them all together, and what you end up is the majority of patients, 54% in both groups, had high-risk disease, so either T4 or N2. So they would qualify for that 6 months of FOLFOX. But the flip side of that is exactly what you said about, I'm trying to do some rapid-fire maths in my head, about 46% of the overall cohort then had relatively speaking, low-risk disease, and so would have gotten away with 3 months. So another point to make with regards to just treatment before we get into the results is the completion of therapy, because this is also something that took me a bit by surprise, to be honest. So about 46% of patients in the triplet arm completed therapy. You have to acknowledge, though, that this is a year long of therapy, so it's a long time. The main reasons for early cessation were adverse events and withdrawal during treatment. I'm assuming that means withdrawal of consent during treatment. 6 total patients had a relapse before or during treatment. 5 had a relapse during treatment. And the reason I highlighted that is the thing that you're always afraid of with any adjuvant therapy is you're giving someone treatment and then they relapse while they're still on treatment. That's the absolute worst case scenario. And there were 5 deaths during treatment. 2 of those were deemed to be potentially due to the treatment that was provided. The rate of completion was significantly lower in the triplet arm compared to the standard of care arm. You could probably put that down to the fact that the treatment arm went for 6 months longer, I reckon. So now we get to the results because I'm keeping half an eye on the time. So the 3-year DFS, 86.4 compared to 76.6% with a hazard ratio of 0.5. So that's a 50% reduction in the risk of disease relapse or death at 3 years. And the important thing to remember here is, and this is sort of a bit of a discussion point because the data from this is more than 20 years old. It's about approaching 30 years old, I think. But
definitely older than you.
Yes, definitely older than me with my youth.
Standard ASCO joke. I bring it out every time.
I think you bring it out pretty much every week, Josh. But according to this relatively old data, which predates a lot of our treatment, so it might actually be a bit out of date, but more than 90% of recurrences following resection of the primary colon cancer will occur within 3 years. So if you're and it's a bit of a strange way to think about it, but if you are going to recur, it's unlikely to happen after 3 years. So 3-year disease-free survival is probably not a bad marker of long-term outcomes. The benefit was consistent regardless of central or local MMR testing. That's just a good, quality flag. It was also consistent across subgroups. The magnitude of benefit appears consistent regardless of stage. So, high risk versus low risk. And it was slightly less clear. The benefit was slightly less clear in young patients. The confidence interval just crept over that line of equivalence, which means it's theoretically possible, but the range was a hazard ratio of 0.36 to 1.04. So there's a good chance that it's still beneficial in younger patients. So in terms of safety, there were no real new safety signals, to be honest. There's not really much to say. So very, very exciting study, and one that I think will probably become a standard of care soon before it becomes eclipsed quite quickly. And I'll talk about why. So as I said at the start, we have seen a lot of very, very exciting data about the use of immunotherapy in the neoadjuvant space. And that's sort of where oncology is going in the early cancer phase. Not for nothing, the discussant for this study was Dr. Miriam Chalabi, who is famous for the Chalabi plot, or the Chalabi waterfall plot, that 100% response rate in the Niche 2 study, and her point was very, very much pro, pretty understandably, the use of neoadjuvant immunotherapy over adjuvant. A couple of notes with Atomic, though. So T4N0 tumours were excluded because you had to be stage 3, and I thought that was something that was interesting. Again, this is data from IDEA, so it wouldn't have been apparent at the time that the study was done, but these are tumours that, even though they're technically stage 2, have been shown to have about the same, or in some cases worse, recurrence rates than stage 3 cancers. There's also questions about how much benefit the chemotherapy adds. Now, there is a little bit of disagreement, or there was a little bit of a disagreement at the presentation, because yes, the 5FU question is one thing, but there is still thought to be a bit of a benefit from FOLFOX, largely driven by the oxaliplatin. So 5FU is one thing, FOLFOX is quite another. So it might be a little bit premature to say we can cut the chemotherapy. It's a nice thought, but it's probably a little bit premature to say that. Dr. Chalabi also talked about the potential for, in this study, an atezolizumab only arm to that vein, but at the time, because this also predates a lot of the data in the metastatic setting, it was thought to be actually unethical to include that study. They thought that it would be so inferior to chemotherapy by itself. Obviously, now we probably know better. And I guess the question that I had was, is there an impact on efficacy in these patients, if you use atezolizumab here, is it going to be less effective in the patients who relapse? So, and timing of relapse probably plays a part, but are we actually attenuating or priming the tumor, increasing resistance in the tumor, and therefore decreasing the efficacy of it in the metastatic space? It's not a reason not to do it. We always say you've got to put your best treatment first, but it is something to consider. So that was Atomic. There are lots of spin-offs. They're looking at ctDNA. They're looking at Lynch syndrome populations. But it's a very exciting study. And what I think, as I said, is I think that it is the sort of thing that will become a standard of care. And then the neoadjuvant stuff will come in. It'll be adjuvant atezolizumab in lung cancer, where, addition of atezo to chemo in adjuvant treatment of resected lung cancer, great. And then Checkmate 816 comes along and all of a sudden no one's using adjuvant atezo. I think it will be superseded quite quickly if, I think it's niche 3, which is the phase 3 study for neoadjuvant immunotherapy in this space, is as positive as we expect.
Yeah, interesting. I agree that it's a good study and it's a subset of patients. We have to remember it's not everyone. It's going to be a lot like many of the other trials that are coming through where they're being superseded by better treatment up front, which is, the doctrine as it stands.
It's the nature of things. Yeah.
Yeah. So look, I might move on and talk about my trial. I'll talk about Matterhorn.
It's such a great name.
Oh, I know, right? I was just like, and the person who supposedly was finishing this manuscript was literally climbing to base camp or something like that. Now we're doing it while climbing to base camp. I don't know.
So they clearly had mountains on their mind.
Right. I feel inferior. Just hearing that. Anyway, so what is Matterhorn? It was a late-breaking abstract. It was the event-free survival data of a randomized phase 3 study of durvalumab, which has made a resurgence this year. I feel everything's Durva. Yours wasn't Durva, but I feel everything's Durva.
Yeah, I think after, what was it, Niagara at ESMO last year, Durva is the hot belle of the ball again.
That's it. Plus fluorouracil, so essentially FLOT chemotherapy, oxaliplatin and docetaxel in resectable gastric and GOJ junction cancer. The takeaway, it works. I think we can sort of say that. You can stop listening now. You've got to 16 minutes.
Thank you for listening. Yes, we'll see you next week.
I'll continue. So the issue with gastric cancer and GOJ cancer is that lots of people die from this, is that it's a 5th leading cause of death. A lot of people present late. 50% is the stage 3 cure rates. If you compare that to colorectal, it's 75. You compare that to breast cancer, it's 80% plus, right? So there is this big burden of unmet need of patients who recur, and it's a nasty, nasty disease. What we do know is that FLOT has improved survival when combined with surgery in sort of the perioperative space. Usually that's 4 cycles before surgery, and if you're fit enough, 4 cycles after surgery. My experience, Michael, with FLOT is that it is pretty nasty post-surgery because people are quite conditioned.
Yeah, and
deconditioned.
Well conditioned. They come out of surgery being really buff. And I've been told that the most important part of perioperative FLOT is the 4 cycles before surgery as opposed to the 4 cycles after.
That's it. It's a nice to have, so to speak. And so they know, I think three years ago, it came out that giving PD-1 inhibitors immunotherapy in the metastatic setting worked really well. And that was really nice. That was nivolumab. We did a couple of episodes on that. That was quite hot. So this trial was adding Durva to FLOT, right? And the historic treatment is either FLOT, 4 cycles before or after, or sort of chemoradiotherapy, right? If you're looking for that trial, it's the AIO4 FLOT4 trial, and the median disease-free survival was 30 months for surgery, which was 18 months, and overall survival was about 50 months. I bring that up because that's sort of some important benchmarks which you shouldn't compare. I appreciate that, but it's important to sort of understand where we're sitting. This trial design, slightly different, and I don't know if it's contentious, but it's interesting. So the standard, it's the cancer types we want, no evidence of metastatic disease. They're stratified depending where you lived in the world or whether you're Asian. And then you were given durva plus flot for 2 cycles versus placebo plus flot for 2 cycles, then surgery, then another further 2 cycles of flot, and then, like everything else, durvalumab for up to 1 year. Adjuvantly.
And Josh, I'm looking at your notes here, and I'm noticing, because you mentioned was it checkmate
657 maybe?
It was one of those. 689, one of those. Is that PD-L1, number one, they're using TAP rather than CPS. I was wondering if you knew what TAP was. It's like tumor assessment something.
Yeah, not really sure.
Anyway,
percentage score.
They're not using CPS, which has sort of been the go-to in gastric, and they're also not using it as a selection criteria, which again is different from those metastatic studies where the benefit, you really had to have a CPS of 10 or more.
That's a good point to make, and we'll
which
get
is
to that in the
interesting.
results.
Yeah, there you go. Stay tuned.
All right, so the primary endpoint, which is event-free survival, had 41% maturity, and then the secondary was the overall survival, PCR, DFS, disease-free survival, and R0 resection. So 900 plus people, which is great. I think it was done during COVID, so kudos to that. When you look at the patient disposition, most people got to surgery, so that's pretty good. And 70% received adjuvant therapy in both arms, which is pretty decent. And 50% completed durvalumab or placebo. And 60% completed flot in both arms, which is what I was sort of expecting. You're going to get that drop off because of toxicity and issues. So baseline, PD-L1 was greater than 1% in 90% of both cohorts. I don't know if that's just the tumor biology itself. I'd have to sort of look that up, Michael, unless you know.
I honestly don't know what the proportion is. And again, they are using a different assay to what we would have used in the past. So
70% were node positive and 27% were that really nasty type of gastric cancer, which is the diffuse. The less nasty is the intestinal type. So the primary endpoint, the median event-free survival was not reached, a hazard ratio of 0.71 versus the placebo arm being 32.8 months. Right. So at that 24-month mark, you see quite a nice division of those curves, and the percentage-wise was 67 versus 59%. So 8% absolute difference of event-free survival at 2 years. So not too shabby, Michael. You move to the classic forest plot. They love it. They say everything benefits, and then you have these things that kind of cross that confidence interval. I'm still yet for someone to be like, oh, well, maybe it doesn't work here as well. But overall, it does, or across stratifications. And also for those that had sort of less than 1% of PD-L1, there was also numerical benefit, but not statistical benefit for a very small cohort of about 95 patients. These secondary endpoints, and I'm whizzing through this with time-wise, the overall survival whilst immature was 0.78, and it is I guess it's suggestive but not definitive, and that's for 47 months in the control arm. And PCR was over double that in the durvalumab arm, so 19% in durvalumab, 7% in the placebo group. And disease-free survival, again, not reached in the durvalumab arm, and 39 months in the control arm with a hazard ratio of 0.70. The 24-month, also there was about a 9% benefit favoring durvalumab. So I hope this is showing the picture that adding immunotherapy, like every other cancer we give, is improving PCR, event-free survival, disease-free survival, and probably will, with time, and I say this with a caveat, Michael, buy a coffee if I'm wrong, will probably improve overall survival purely for no reason as opposed to the fact it's such a nasty cancer.
Yeah, I think that's pretty safe because the lower limit of the event-free survival here is 40.7 months. And as you so kindly mentioned in the original FLOT trial, the overall survival is 50 months. So unless people are, falling to pieces very quickly after recurrence, then I think it's got a good shot.
Yeah, I agree. I just like to say until we get the final analysis,
Yes, got to
don't
hedge your
eat my
bets.
hat. That's it. And adverse events wise, slightly higher in that of the intervention arm. Grade 3 or 4 was sort of 72 versus 71%. Serious was 48 versus 44%. I mean, realistically, it looks like it's equivalent. I think that's it. But also, there's only 4 cycles of FLOT. Maybe there's not enough cycles for them to have so many side effects that you'd anticipate. But you did see the common things: diarrhea, nausea, alopecia, fatigue. What is my conclusion though? Because I think that's probably more important. It improves event-free survival. This will likely become the standard of care, pending OS analysis and approvals. Depending on what country, with us, it'll probably take a little while. But there was actually some interesting discussion points and some interesting questions, Michael. There's been other studies that have looked at very similar regimens which have been negative. A prime example was Keynote 585. Yes, they use cisplatin as the chemotherapy backbone, but their 24-month event-free survival rate was almost identical. And I'm not sure if you can see that's a different sort of Kaplan-Meier curve I've got on my screen, which people can't see, but they've sort of superimposed a number of the trials. So the FLOT durvalumab arm, the FLOT placebo arm, and then the FLOT trial from the original FLOT 4 trial. And you can see there is very much parity when it comes to the control arms. They look almost identical, and the intervention arm looks a lot better.
So with Keynote 585, did they say why it was negative if the 24-month EFS rate... Are you saying the 24-month EFS rate with Pembro was almost the same as without?
Yeah,
okay.
Yeah, that's it. So it could have been the chemotherapy backbone, I think. I think there were some potential issues with the trial design, he was saying, and it was quite a complex trial design and quite a complex statistical analysis, where I think when they went for the new Matterhorn, it was quite simple. It's like A plus B versus A. Proceed. That's what it looks like. These sort of trials that sort of have very defined endpoints and defined processes, I think sometimes do a lot better. Just the cohort of how it is.
Keep it simple.
Keep it simple. Well, Michael, that's our 2 trials for the night or the day, depending.
I do want to make one final point about Matterhorn that I thought was really interesting. A final rejoinder to leave our listeners on is that both the study and the control arm only had 2 cycles of FLOT before and after, when the standard of care is 4. And yet you've got pretty much, as you said, very pertinently, pretty much the same EFS, not just the same numbers, but the same trend in the, I think they called it, what did they call it? They called it DFLOT, dose reduced, I'm assuming.
The D is for durvalumab.
Oh, durvalumab, right.
Durvalumab. What?
But but the FLOT placebo arm basically tracks the original FLOT. So are we actually just over-treating, leaving aside durvalumab, are we currently over-treating patients with gastric and gastroesophageal junction cancer? Are we giving them basically double the chemo that they need?
Well, potentially, but potentially not, because a lot of people didn't end up getting all of the FLOT. So, that's the other thing. And maybe, as you said, the majority of the benefit is in that neoadjuvant space. And as we sort of move more into the neoadjuvant sphere, we'll also have fewer chemo that we need to give and maybe better outcomes. So, it could even look at it as a de-escalation trial. De-escalation durvalumab, differentiate a FLOT.
Well done.
Thank you.
Could tell you were struggling there, but yes, we do love less chemo on this show.
That's it. And what do we say what we're doing next, Michael? We've got another plenary session coming up, so you should just tune in.
There was just too much for us to get through in one session, so we've got 2 episodes, and one of the studies, Josh's study, is his favourite child amongst the 4. I think it's
That's it. We'll see you then, Mikey.
Bye. Thank you for listening to this episode of Oncology for the Inquisitive Mind. produced by ADC Productions with the assistance of education grants from Pfizer, Gilead Pharmaceuticals, and Merck Pharmaceuticals. As always, these companies do not receive early previews or editorial input of any kind. The opinions expressed in this episode are our own, and the facts are, well, the facts. If you like this episode, please consider subscribing to be among the first to hear our latest forays into the ever-changing world of medical oncology. You can find previous episodes of our show, including coverage of major conferences, interviews with world-renowned experts, and much more at inquisitiveonc.com. If you would like a particular subject covered on the show, drop us a line at inquisitiveonc@gmail.com. And if you happen to be in Australia, stay tuned for details about exciting in-person events we have planned for the near future. Thanks for listening, and we look forward to demystifying oncology again next time.